You're watching Byline Wilmington on CBS 10 WILM. Here's your host, Don Ansell.
Okay, we're back. Dr. Will Russell, a leading urologist in our region, is our guest. We're talking about the #2 killer of men in America, prostate cancer. And as if you weren't here at the first segment, I've been through the process. I was diagnosed in 2007, and I'm cancer-free with prostate cancer today. So I was successfully treated. The PSA test, it's a blood test that detects a certain protein that is produced if there is a growth in the prostate. Is that accurate?
Sure. And it's been around since about 1986. And
recently it's come under fire. People say, it's antiquated. It doesn't really tell you what you need to know, and it may lead to unnecessary treatment. Comments?
Well, I think all of the arguments have always been there. If you look at how they found the PSA test, what they did is they found this test and they found that it's higher in people with prostate cancer. But then what they did is to figure out who to do it to, they just biopsied thousands of men, checked their PSA, checked their prostate exams, and then they went backwards and said, let's find a PSA level that
indicates danger?
That indicates a certain percentage of men. So if we're looking for, say, a 20% yield from this test, let's choose 4.0 as anything above 4.0, you have about a 20% chance of having cancer on a biopsy. Anything below, it falls to probably less than 5. And so you can move that number around, and you can find more cancers if you lower the number, and you can find fewer cancers if you raise the number. But when you get more real positives, you get more false negatives too. And so
does it not raise the PSA number if you have an enlarged prostate but you do not have any cancer growth?
Sure, it can. Infection can raise it. Enlarged prostate can raise it. Some kind of manipulation that you've had on your prostate, example, a prostate exam, it's probably better to get the PSA a moment before the prostate exam than afterwards. And so sometimes we give people an antibiotic and then repeat the PSA.
To make sure they don't have an infection, it's not raising the number. So at what point do you say, and I know with me, I had a very high PSA normally, and we accepted that and then it spiked.
Sure.
And you said we need to.
And I think when you criticize the test, one of the things they do with the test is they say with one PSA that leads to a biopsy, which leads to treatment, which leads to side effects or whatever, how are we going? But if you take a bunch of PSAs, it's like looking at a stock value today and saying, is that a good stock to buy? What's your PSA done in the last 1, 2, 5, or 10 years? So a PSA that's doubling every year is certainly something you want to look at. That's what cancer does. It
All right,
doubles.
so you take a biopsy and you see, there's a growth. Now, how do you know how aggressive that growth is? Maybe it's one that they can live with forever.
Sure, and I think that it is the pathologists give it a grade. We call it a Gleason score, of somewhere between 1 and 10. The higher grade cancers are faster growing and warrant treatment. The lower grade cancers possibly don't. And also the number of biopsies. If you had 1 out of 12 biopsies positive, that's not as severe.
But I had 1 out of 12, and you said it was a fast growing.
If it's the grade of the cancer and the Gleason score. If your Gleason score is 7 or 8,
it's out of my pay range totally now.
then if your grade of cancer, according to the pathologist, is higher, then you're a grade.
So there are certain benchmarks that determine that?
Sure, yeah, there are. I think that once again you go back to 2 men who even have the same grade of cancers, but one guy's PSA is doubled in 1 year and the other man's PSA is doubled in 10 years. Who should be more concerned? One guy has 5 biopsies out of 12 that show cancer, and one has 1. I'd go after the guy with the 5 out of 12 with the PSA doubling every year.
And considering it's the #2 killer of men, if you're diagnosed with prostate cancer, so you might not want to hear it's a slow growing. Do you have people say, I want it out?
I think that personal preference is probably the biggest determinant of how people get treated today.
And is the treatment depends on what they say? What a patient.
Sure. I think that it is in prostate cancer, the most important thing is the hand that you're dealt. The second most important thing is how you play it. But if you get a well-differentiated cancer, you can do nothing. You can give radiation. You can do surgery to remove it. You can
Seeds,
freeze.
hormone treatment?
Sure. And the hormone treatment is generally reserved for people who have metastatic prostate cancer, who by itself.
Although I did radiation and then was, I think you suggested or was suggested that I also do hormone treatment.
Short term.
Short term.
And what that does is it shrinks the prostate, sometimes makes it easier to treat, and makes it more sensitive to the radiation. The hormone therapy by itself, well, when you really think about it, the first Nobel Prize to a urologist came in 1940 when they realized that removing men's testicles would stop their prostate cancers from growing. But that was
because that produces testosterone,
Right.
and that is what that cancer feeds on.
Right.
Is that correct?
Right. And so then from 1940s to the
glad they got over that
1970s,
one.
well, yeah, they now have shots, but from the 1940s to 1970s, really, there was no way to screen for prostate cancer, so almost every cancer you found was an advanced prostate cancer. The year before PSA came out, only 5 to 10% of people who were diagnosed with prostate cancer had it discovered in an organ-confined state. Now it's approximately 85 to 90% of people who are diagnosed with prostate cancer.
And still it's the second largest killer of men?
Yeah, it is.
That's a shot.
It's the second largest cancer killer of men.
Cancer killer.
So when you
but
look
still, that's, I mean, what's number one?
Lung.
Lung?
Sure.
And then prostate.
Lung and prostate.
And with all the advancement and the testing and the treatments, and it's still number two. Where's the missing piece?
Well, it's so, the challenge is that the number of cancer deaths in the 1980s were about 47,000 per year.
Total.
Yeah, I think
cancer.
I think the total losses in Vietnam were in the 30,000 range, just to give you a perspective. So, if you look at now, it was 42,000 then, it's 27,000 now. So, what we're doing has reduced the prostate cancer rate by 40% in a population that's aging. So you should have seen the rise that would come with our aging population, and yet you've seen a 40% decline. I think you have to attribute that to, one, screening, and two, treatment. And you can't have treatment if you can't screen.
Is the incidence, or is there no way to know this, of prostate cancer increasing? I mean, could there be environmental factors? Do we know? Do you have suspicions?
I think there is a wide variety of prostate cancer incidence in groups. Higher fat diets, I think, are why Western people have more prostate cancer. And our aging population. If you go to, for example, pick a country, Zambia, I think the average life expectancy is 38 years. You're not going to see a lot of prostate cancer because people are dying young. You're also not going to see any screening for it. So people are dying of unknown cancers, some of which are prostate cancers too. So I think in our area, it's a combination of things. But I think our higher fat diet's a big factor.
We're going to take a break. When we come back, talk about a trip that Will recently took to Haiti for a week. We'll talk about that, and we'll talk about this headline-making vaccine that they say could treat prostate and maybe some other cancers. Stay with us.
Thanks. Yeah, I'm